Hey everybody, it's Matt Shu from Upright Health, and today I want to talk about a topic that I have touched on in the Upright Insider membership site, but I really wanted to go a little bit more into that topic here on YouTube so people can get a taste for what I'm thinking about all the time. Okay, so basically in that previous video I was talking about objective information and subjective information. Objective information is the type of information that people from the outside can see and measure about you. Subjective information is the information you know about yourself that you can report to the rest of us. Okay, so this is you're in green, and this is your description of a problem. This is all subjective information. Objective information is everything our expert, the man with the big hat and glasses, can figure out about you from observation, from whatever tools and measuring things that he has. He can get that objective information because those are things that are verifiable, that he can say, look, I used the tool, it gave me this result. And if you use that same tool and measure, you're going to get the same result, right? So in the world of medicine, the objective tools are super useful for a lot of things. If you have a bullet in your gut, it's pretty useful to be able to see that there's a bullet in the gut and you need to take that thing out. If you have a punctured lung, if you have a broken bone, if you have God forbid, a cancerous mass in your body, those are all things that objectively seeing are really, it's really important to see those things, right? So the big hat needs to use objective information to help you help yourself, right? Or just to help you. Not necessarily to help yourself, but to help you. So the problem that we run into is that with musculoskeletal issues, the information that Big Hat, or the tools that Big Hat has to help you are not that useful. So he's looking for objective information using x-rays, MRIs, injections, and sometimes manual muscle testing. Now, the problem, to keep it really brief, I've made so many videos about this already, the problem is that the tools used to gather objective information are not giving any useful information. So x-rays are well established at this point to not really correlate with any sort of movement problems or sensations like pain. So x-rays and MRIs, same thing. The things you find in those things don't really seem to give you useful information or predictive information about how you're going to feel, right? You could have x-rays that look terrible, that look like you have horrible arthritis, that look like you should just be miserable right now. And you may feel nothing because what you see in the x-rays it just doesn't line up. Same thing with MRIs. You could look like you've got, you could have tears, you can have labral tears, you can have whatever. You can have cysts, it doesn't matter, you can have them and you can still have no symptoms. So those things don't seem to line up with the subjective reports, okay? So not that useful. Injections are sometimes used to try to narrow in and be able to say like, oh yeah, the pain is definitely coming from that. But like I've done videos on this before with like hip injections, they don't actually tell you anything. So they can definitely numb things. That's not under debate. You can inject a numbing agent into somebody and numb stuff, but these actually don't really have predictive value about what's actually going on. So again, this doesn't help the big hat understand what's going on with your subjective report. And then there's manual muscle testing, which very rarely gets used. I'm gonna put like range of motion tests under this too. And those range of motion tests, they're generally either insufficient, I would say, they don't measure the right things, or they're not used, or they are really maybe not properly applied is the polite way I'm thinking of putting this. But basically, there's a lot of room for error with manual muscle testing, and I would also say a lot of times it's not measuring the right things. I haven't seen any good studies about this, but basically, I think this is on the right track, but even right now, I think it's just not used that much, and even if it is used, it's pretty error prone. So you have these four things that these top three get used a lot, and they actually give you no information, and then you have this last thing, which just, could give you shoddy information if you're even using it. So the big hat is essentially flying blind, but doesn't realize that he's flying blind, right? He's got these three things that he's relying on, but these things cannot be relied on. So you have this whole subjective report, and this is all mostly being ignored and not being used in any useful way, right? It's just like, okay, well, you're telling me you have these problems, so let me try to match this up to a knowledge base that I have using tools that, if I'm being honest, I know are not particularly accurate, okay? So let's assume that these things were accurate. Then what would happen is you'd have to look at the subjective reports and then see with the objective measures how they match up to these theories. Now the problem, this is just a general weakness of human life, then it's the nature of solving any problem, is you have theories about what needs to happen to solve the problem. In medicine, especially with musculoskeletal stuff, you're limited to a certain, it's a shockingly finite number of diagnoses, right? And so let's say you have hip problems, there's only going to be a couple recognized diagnoses available for the big hat to give you for your hip problem. You might have bursitis, maybe you have a labral tear, maybe you have iliopsoas tendonitis, or maybe you have FAI. If I missed something, let me know. But those are like the most common hip diagnoses that you'll hear. Maybe like IT band tendinosis, something like that. So you have a very small number of possible theories, and they're all geared towards looking at one muscle and saying, oh, it's this muscle's fault, or saying it's this bone's fault. It's just this one anatomical thing's fault. So the assumption is that the list of diagnoses is complete, when in reality there can be a whole lot of other things, right? We might have E, F, G, H, I. We could have an endless number of other options here that are simply going unrecognized, which is what I would submit is generally happening with musculoskeletal issues. So, right now there tends to be this focus on, well, it's this anatomical thing, it's this anatomical thing, it's this anatomical thing. You just need to correct that small anatomical aberration. Sometimes that involves cutting out a piece of bone, that involves cutting out a piece of soft tissue, that involves cutting a piece of muscle to relieve tension. Those things, when you say them out loud, should sound a little funny. Because if you have that soft tissue in there, why are you going to go in and take it out? We're assuming that the subjective report of pain that you're giving, let's say, my shoulder hurts all the time, we're assuming that pain signal is wrong for some reason because it doesn't match up to our objective measurements. So think of it this way. I say my shoulder hurts. I come to the big hat, and the big hat says, well, the x-ray is fine. The MRI it's mostly fine. Nothing in there seems to explain that. The injection seems to numb it. The manual muscle test, you fail. Well, let's try numbing it some more. Still didn't fix it. Let's try moving it a little bit, doing something like that. Didn't fix it. Well, if it's still hurting, maybe we should go in and cut something. And that doesn't really make sense, does it? No. I've read reports of people who have constant pec minor tension who actually are told they need to cut the pec minor surgically to relieve the tension. Well, what if there's something about the way muscles interact and the way the nervous system uses muscles? What if there's something about that can be done to just restore proper balance so you're no longer getting that experience of pain and discomfort? What I would suggest needs to happen is we need to start thinking about what does that subjective information really mean, and how can you utilize it? If somebody is telling you a muscle is constantly tight, feeling constantly tight and sore, that doesn't mean there's necessarily something wrong with that muscle. That can mean something else is going wrong and you need to deal with that other thing without going in and cutting it. These objective measurements, in my opinion, are just sort of crazy. That doesn't mean, however, that there's no other way to objectively measure things. So what I would suggest is manual muscle testing is actually kind of on the right track, but basically what you want to be looking at is how people move, right? And how it feels to them subjectively when they move. Because that subjective sensation is the most accurate reflection of what's going on. And if there's something off about how they're feeling things, then that can be improved, right? So it can be a little complicated because some people have poor body awareness. In that case, visual assessment of how they're moving is really, really helpful. And you can gradually help people get better at feeling their own bodies. And as they get better at feeling their own bodies, they get better at moving their own bodies and controlling their own bodies. The objective measurements that I think people need to really think about are all about movement and all about function. Does it hurt when you're sitting? Why might it hurt when you're sitting? Besides anything that shows up in here, what are other reasons your body might hurt? Can it just be from lack of blood flow? Can it be because muscles are atrophying? Why would it hurt? Why would it hurt when you raise your arm out to the side? If it's not a bone, right? If it's not some weird growth, like some bizarre giant growth in your shoulder, which it basically never is, what could cause these things to move improperly? And the answer is, well, muscles not being controlled well. So rather than use movement as a red flag and say like, oh, if it stopped moving, then that means there's an anatomical problem, we should be thinking about thinking about movement tests as a starting point to troubleshoot. Okay, right now we just say, well, if you can't do that motion, that means there's something wrong with the bone or the cartilage or something, when we should be thinking about it as, oh, you can't move that way. Why is your body not allowing you to do it? What is the muscular thing that needs to change? What is the neurological thing that needs to change to help you move that way? And that, I think, is the most productive way to think about issues with joints and issues with, pain near joints and pain around your body. So I hope that gives you a more helpful, more productive perspective, and I hope you remember that pain sucks. Life shouldn't. If you liked the video, don't forget to like, share, and comment, and don't forget to subscribe.